Welcome back. We have around 200 people watching us live. And please use the chat and ask us questions. And we'll be delighted to answer them together with our distinguished faculty members. Before we let our speakers and faculty members in, I would like to congratulate my partner, Professor Oshkinis, for using radial access for peripheral intervention. I think if you try hard enough, maybe one day you can become a cardiologist. What do you think, Grzegorz?
Oh, I always want to be a cardiologist, but I think that the best one are going to the cardiology. After that is vascular surgery. But anyway, I think that the radial access is really interesting modality for the especially iliac segment and common femoral artery segment. What I said that right now on the market there are not too many devices, but probably because of the very early ambulation and possibility to discharge patients in a few hours, it will expand in the future.
I recall that several years ago when I was giving a lecture, I believe it was in Dubai, I talked to a vascular surgeon about radial access for peripheral interventions. He had absolutely zero belief in it. He said it was wrong. And here we are.
Yes.
And we do a lot. And I think if there is a message, one of the messages from this conference, one of them would be to think about access not only as femoral, but use a lot of alternative access.
I try to follow you cardiologists very carefully. so this is my decision to start. But you are right that vascular surgeons, they don't believe that puncture the radial artery is safe. I think that another problem is that vascular surgeons don't use the ultrasound access, and they don't use it as a tool to help to make a hole in the artery. Maybe we try to be very quickie, but sometimes it makes a lot of troubles if there is a bleeding after that. And also the vascular surgeons, they do believe that after puncture the radial artery, this radial artery will close. But it's not true, of course. This is our feelings. This is not the knowledge. But sometimes it exists that we do believe that something happened, but we don't prove it. Mm-hmm. So I always try to, at the end of the procedure, I do the ultrasound investigation, and I prove that 99% of the radial arteries are patent.
I think we'll have plenty of time to talk about radial access throughout the whole conference today and tomorrow, but I think now we are really excited to bring our guests in. Professor Kobajder, Professor Kalena, Professor Dziedzikowicz, welcome, and we really enjoyed your lectures. Welcome. Can you hear us?
Yes, I can hear you.
Let me start with Professor Kobajder from Paris. We absolutely loved your case. And each symposium obviously should have high educational value. And I absolutely love dual access. So I think it was very important for all our viewers from Kamchatka to Alaska or the other way around to learn dual access. Tell us, in what cases do you use dual access? And go ahead, Professor Kobajder.
Well, we reserve dual access whenever we have a failure of having a retrograde access. The first attempt is to have a retrograde access. So if we can find any distal vessels to canalize, we stick with only the retrograde access. Whenever we don't find where is the origin, it was a case in the case that I presented, whenever we don't find the ostium or the origin of the tibial arteries, we don't try to avoid to lose a lot of time of contrast and X-ray exposure. We shift very quickly to distal access. One of the constraints of distal access is sometimes if patient have a lot of pain, of distal pain, so with critical limb ischemia, you need to go on the general anesthesia because it's hard for them not to move and to have a good puncture. Even if you use ultrasound, they have to have it trying to move. So let's say in the majority of the cases, we stick with the antegrade But in some, that's 10% of the cases, we need to have a dual access.
Thank you. What about your second case, your AV fistula? I mean, doing a stent graft above the knee, kind of a no-brainer, I would say. You don't want to embolize it. You just want to cover it with a covered stent. But the challenge we see is if you have significant AV fistula actually below the knee, what would you do then?
Well, if we have it really below the knee, we would try really to get it embolized and avoid to put any type of stent below the knee. But the majority of the cases, the AV fistula below the knee are not very high flow. So we have not too much concern about having AVF below the knee. Most of them are post-traumatic and they don't have a lot of flow, though they don't steal too much. The majority of the AVF fistula who have really high flow are above the knee or on the common femoral artery.
Thank you very much. Grzegorz, back to you.
Professor Dziedzichovich, you showed us a very interesting case. Telling the truth, I've got almost the same case, but I was a little bit afraid of putting the cover stents, and I do open. Because sometimes it's difficult, especially in such calcified aorta, to manipulate in this region. You know, the possibility of embolization is very high. So don't you think that it could be possible, and it's maybe to put something, you know, because I would be a little bit worried about problems with intestinal problems after that.
Okay, thank you. So this is exactly why I have chosen the cover stents, because the cover stents separates the plaque, the atherosclerotic plaque, the thrombus from the lumen. And I think, and I believe that the risk of embolization is significantly lower, in distal embolization. And that's why we also have chosen the cover stents to ensure the flow to the superior mesenteric and celiac trunk. So I think it's a new technology and widen our possibilities of treatment of different pathologies, complex pathologies.
So, Professor Dziedzichovich, this is Jan Skowroński. As you know, I'm a cardiologist. I'm not a surgeon. And I have to admit that for many cases, if there is a napkin ring, very short critical lesion in the distal abdominal aorta, I actually just use regular stent. You can do it through 7 French. You can use a 10 millimeter stent, and then you can post-dilate it to about 14 millimeters. It is, of course, not optimal. It's not exactly the size of the aorta, but it usually relieves the patient of the symptoms. I don't know. What do you think? Would you use a regular balloon expandable stent below the renal arteries, or would you still use a graft? Thank you.
Generally, I feel more comfortable with the cover stent, with the stent graft, because what may happen in the aorta, especially heavy calcified aorta, we may have some rupture that is limited, but in the aorta may cause really important bleeding. So maybe it's sometimes a little bit exaggeration to use a cover stents in every aortic lesion, but it definitely gives more comfort, and I feel safer with them. And as long as I am until now, I've put many of them in an infrarenal position, doing a so-called CERA procedure, and I'm really very satisfied with the results.
Thank you.
Thank you. I'm sorry, Professor Kobajter, what is your opinion in that situation? Do you use the cover stents or do you use the regular bare metal stents? in the distal part of aorta and proximal part of both iliacs?
I know that it's in a lot of centers, and also in our center, we have a trend to really move into putting cover stent. As it's been said, that we have now a lot of follow-up in patients having cover stent in the SMA, the celiac trunk, and renal artery with fenestrated stent graft, and the results looks to be very good. And some of the trials also assessing the cover stent into the SMA seems to have better results than non-cover stent in terms of restenosis. So I would say whenever we have the opportunity to put a cover stent, because we could put a 6 or 7 French sheaths without too much difficulty, we have the trend to go to covered stent into the iliac and also in the visceral arteries.
Okay, thank you.
Thank you very much. Professor Helena, we loved your 4 French case. I remember when I was starting my training 15 years ago or so, everything was 6, 7, 8 French, and now here we go. We have 4 French equipment that you can do the whole iliac and SFA case. The place where I am in the United States, almost nobody would stay overnight for endovascular procedure. Essentially, everyone goes home. So minimizing the French size, we find actually important. I don't have equipment you do, but I think this is the trend that we see, smaller and smaller. What do you think? I think we lost
connection.
We lost connection with Professor Helena, unless we have him. So let's go briefly to the radial.
We've got him.
Do we have Professor Helena live?
I'm there.
Here we go. Okay.
Yeah,
Thank you.
I'm live. The first time the company approached me with a 4 French platform was about 10 years ago, and I was very skeptical. And a month later, I had a patient with critical limb ischemia with no upper access. And I did a case completely through the posterior tibial artery. So I punctured, I used the 4 French sheath, and I delivered the stent. And this was the breakthrough moment. And I'm looking to use 4 French size everywhere I can, especially for diabetic patients with critical limb ischemia. When you cannot puncture the common femoral, or there's too much fat or scar in the groin, I can easily puncture the proximal part of the SFA with a 4 French sheath. I think this is a very safe technique. You just compress and you simply get away without any bleeding, sheath being broken, etc. Well, I recommend to all of you using 4 French platform whenever you can.
So Grzegorz, a question. Why do you keep patients overnight in Poland and in Europe after endovascular procedures? We send everyone home. We usually, I think we would use a vascular closure device in about 90% of cases. Why do these poor patients need to stay overnight in the hospital? What's the reason? Is it the payment?
Well, when I'm watching television, I learned that the Polish is a very rich country now. So, of course, there was a joke. I think that how much money do you lose by keeping the patient in the hospital in the United States? Is it $3,000, $2,000 or more?
No, we don't. We actually, the payment from the insurance is actually a little bit smaller if you send the patient home the same day. But it just doesn't make sense for anyone. For the cardiologist or the operator who has to come the next day to discharge the patient, for the patient, because there is always a risk of some error, wrong medication, and patients are just like going home. I would.
Yeah, but we have to ask our authorities, because probably we know that many endovascular cases we are able to discharge the same day. But it's impossible. It's a history. The people are afraid. The angiologists, vascular surgeons are a little bit afraid but also, I think the main thing is that the patient don't want to go home the same day. They are afraid of their health. They want to stay more and more in hospital. They feel better. They feel safer. You know, this is
I completely disagree. We see absolutely.
But you know, I am talking about the Polish people.
Different Polish people are not different than anywhere else. Especially during COVID, patients are afraid of healthcare institutions. So actually, institutions, at least in the U.S., that had in the protocol of sending the patient the same day, they were able to much easier convince patients to come to actually have a procedure that was necessary.
All right.
Okay.
Thank you very much.
Thank you very, very much. Wonderful, absolutely fantastic lectures. Thank you for joining us. Encourage your friends and colleagues to join the conference. And please use chat. We will do our best to respond to the questions. I think it was very educational.
I hope our whole conference will be very educational. So thank you again. Thank you very much.